Good evening, everyone. Thank you for joining us for Oculus's National Keratoconus Day webinar, Modern Management of Keratoconus from Diagnostics, Progression to Treatment by the esteemed Dr. Peter Hersh, Dr. Stephen Greenstein, and Dr. John Gellis. They all come from the Cornea and Laser Eye Institute and the CLEI Center for Keratoconus, located in Teaneck, New Jersey. The center is dedicated to research and comprehensive management of keratoconus. Additionally, they all hold academic appointment in Rutgers, New Jersey Medical School's Department of Ophthalmology. Before we continue, we will have some time for questions at the end of tonight's webinar. So go ahead and enter them into chat as soon as you can, so we have some time to read over them and get ready for that Q&A session. Dr. Hersh is one of the most respected names in ophthalmology. He founded the Cornea and Laser Eye Institute in 1995 and formally inaugurated the CLEI Center for Keratoconus in 2002. He's been involved in countless research papers, a variety of FDA trials and studies, including crosslinking and LASIK surgery. He has trained over 1,000 eye surgeons throughout the world in corneal surgical techniques. Dr. Hersh has received the Senior Honor Award from the American Academy of Ophthalmology, an incredibly rare and distinguished honor. Dr. Greenstein is one of the doctors who trained under Dr. Hersh and is a doctor who loves research. He's been involved in research regarding refractive surgery, keratoconus, corneal surgery, and he's presented this research at numerous scientific meetings and has co-authored a chapter in a textbook on corneal collagen cross-linking for corneal ectasia. Dr. Gellis is the Director of Specialty Contact Lens Division at the Cornea and Laser Eye Institute and is a well-respected expert in contact lens fitting and keratoconus management. He has several fellowships and focuses on keratoconus, ectasia, post-refractive surgery complications, severe dry eye, ocular trauma, patients who as I was saying, Dr. Gellis focuses on keratoconus, ectasia, post-refractive surgery complications, severe dry eye, ocular trauma, and patients who have undergone intacs, corneal cross-linking, and corneal transplantation. I'm very excited for tonight's presentation. And now, Dr. Greenstein.
Thank you, Matt. Thank you for that introduction. And really thank you to Oculus for inviting us on World Keratoconus Day to give this lecture on modern keratoconus management. So before we dive into the topic, just of course a brief review of keratoconus itself. Keratoconus is a progressive corneal disease. It is resulting from a loss of biomechanical strength in the cornea and focal stromal thinning. It's generally a non-inflammatory disease, and this loss of biomechanical strength and thinning results in an apical steepening. Now, the epidemiology of keratoconus has changed. Classically, it's been reported to be about 1 in 2,000 people, but as time has gone on, more recent reports have really shown that the prevalence is much higher. The most recent report showed that it may be as high as 1 in 84. Now, this can be due to populations and where the studies are taking, but it's notable that this most recent study was done with the Pentacam and more modern keratoconic diagnostics, which may be picking up earlier disease. So it is likely that our previous epidemiology and prevalence based off of classic diagnostics really missed a lot of keratoconic patients. Now, the management of keratoconus really has 3 pillars to it. Diagnostics, which is imaging, progression, and stability of the cornea, which mostly focuses on cross-linking, and then visual rehabilitation, which Dr. Gellis and I will talk about with regard to contact lens management and surgery. So with regard to diagnostics, diving right in, again, the classic slit lamp signs for keratoconus are generally signs of very advanced disease. So significant apical scarring, significant apical thinning, Munson sign, the classic things that we see in the slit lamp are already when the disease has become very advanced. Early keratoconus is generally invisible at the slit lamp. So, and classic instrumentation can miss it. Vision in early keratoconus is generally very correctable, even in eyeglasses or soft contact lenses. Some patients may not be wearing any correction at all. So we need advanced diagnostic instruments to help us diagnose these cases earlier and earlier. And as Dr. Hersh will talk about with regards to cross-linking, this early diagnosis is very important for stability. Now again, earlier topographies focused specifically on anterior curvature and placido disc imaging, but newer modalities focus on Scheimpflug imaging or OCT, which can not only tell us about anterior curvature of the cornea, but also tells us about the shape. It can tell us about the anterior curvature, posterior curvature, and thickness, all with one device. So I think most of us would look at this and know that we're looking at a case of keratoconus. And this is a pretty typical map that you would see with the Pentacam topographer, the top left being the axial curvature, top right the front elevation, bottom right the back elevation, and the bottom left the corneal thickness. And what we can see here is classic irregular astigmatism with inferior steepening, a classic island of elevation anteriorly with an island of elevation posteriorly, and corresponding thinning of the cornea. Now this case might be a little bit more subtle, but you can still see that there's risk for keratoconus here. So again, we see that there's irregular astigmatism with inferior steepening, a more mild anterior elevation, and a more mild posterior elevation, but altogether corresponding to a localized area of thinning. And now finally, this case is not nearly as clear. Again, we see kind of an intermediate area of irregular astigmatism and inferior steepening, possibly some anterior elevation here, posterior elevation, and maybe a mild localized thinning. So there were some metrics that were used to determine the risks of patients when you're looking at topography to determine whether or not you're looking at a case of keratoconus. And some of these metrics were things like a steep keratometry greater than 47 diopters, or posterior elevation greater than 20 microns, anterior elevation greater than 15 microns, and corneal thinning less than 500 microns. But these are really just snapshots of one point on the cornea. More modern diagnostics, like the BAD analysis on the Pentacam, uses an enhanced reference sphere to highlight the areas of disease or potential disease, and uses many metrics all together in a regression analysis to determine whether or not a patient may have keratoconus, and also to determine with some of the other analyses severity of disease. So in our classic case of keratoconus here, you can see that clearly the bottom right value, the D value, which is the total regression analysis, shows that this is clear keratoconus, and red would highlight patients that are generally greater than about 2.5 standard deviations from normal, yellow more than 1.5 standard deviations from normal. So our second patient, which was less clear, we thought does look like keratoconus. The D value really helps us out to show us that this is well outside the norm and clear keratoconus. Even for our intermediate or more mild patient here, the D value on the BAD analysis is very helpful, because again, we see that it's greater than 1.5 standard deviations out of the norm, and it's a cornea to be concerned about keratoconus. Now, the BAD analysis is great as a refractive screening tool, and it's great as a keratoconic screening tool to determine whether the cornea and whether the map you're looking at, how different it is from normal. But once we know that a patient has keratoconus, classification is equally as important. And again, here, advanced diagnostics is critical. Classically, classification has been determined based off of mean keratometry and refraction, particularly myopic astigmatism. But in a retrospective analysis, when we've looked at over 1,000 eyes that have come to our center with keratoconus, we found that about 40% of eyes were hyperopic or emmetropic, and 40% of eyes had a hyperopic, mixed, or no astigmatism at all. So clearly, refraction isn't enough to pick up on keratoconic patients. Similarly, we looked at topography, and this was all 1,000 eyes together. Maximum keratometry was 58 diopters, so clear keratoconus, but even with a 58 diopter mean maximum keratometry, the steepest keratometry averaged 50 diopters and mean keratometry averaged 48.5. Now, if we really break that down and look at the cases that were mild and moderate on the left, what we can see is in cases where maximum keratometry was between 50 and 55 diopters, so clearly had keratoconus, the K steep was only 47 diopters and the mean K was 45.2. If we go to even more mild cases, less than 50 diopter K max, K steep was 44.2 and K mean 43.2. So K mean and refraction is not enough. In fact, you have to be severe, the K max greater than 65 diopters before K steep, K flat, or K mean significantly correlate with K max. So again, the Pentacam with the ABCD analysis uses multiple measurements to give us a much more clear staging scheme for patients who are already diagnosed with keratoconus. And the ABCD analysis looks at the anterior portion of the cornea, the back or the posterior portion of the cornea, corneal thickness, and it can be you can manually enter visual acuity to stage disease. Again, this is taking metrics, many metrics around the thinnest portion of the cornea to look at staging and progression. So if we look at the staging here, again, in our classic case, we can see this is clear. We have a stage 4 anterior, stage 4 posterior, and stage 1 with corneal thickness. So this staging scheme gives us a lot of information now about this patient with keratoconus. Our more moderate case shows a stage 2 of posterior keratoconus and approaching stage 1 for anterior and corneal thickness. And the most mild case is approaching stage 1 for posterior, for the posterior cornea with some changes in corneal thickness as well. So this staging mechanism now really gives us a way to compare many stages of keratoconus, not just based off of mean keratometry or based off of refraction, but based off of multiple portions of the corneal shape. And we can then use these metrics to around the thinnest point to look for progression. So here's a case that we saw in our center. This is a patient who was seen initially for a keratoconus exam, and then was seen 4 months later to determine whether or not there was any change in the cornea. And the ABCD analysis is very helpful to determining progression of disease. We can see here that clearly the anterior surface has gotten worse by the green line, passing the 95% confidence interval in keratoconic patients for progression. The posterior surface has also gotten worse, passing that 95% confidence interval. And the corneal thickness has gotten worse, passing the 80% confidence interval, and it's become thinner, approaching the 95%. We then did cross-linking for this patient, and we can highlight that with the black line. And now we can follow the patient's progression once cross-linking has already been completed. So we now change our baseline exam, which you can see in blue on the left, and that's the green bar, and everything is going to be compared to this exam when cross-linking was done. And what we can see is that the pink, which is 2 years later in 2019, there was no progression of this patient's disease. We looked at the anterior curvature, posterior curvature, and thickness, and this patient's keratoconus remained stable throughout. So once we can diagnose progression, it's important to understand how we treat progression. And Dr. Hersh is now going to talk about cross-linking and stabilizing the cornea.
Oh, thank you, Stephen. I thank you all for having me here tonight. My thanks to Oculus for putting on this webinar and for all of you in attendance in honor of World Keratoconus Day. As Dr. Greenstein just discussed, there have been many innovations in keratoconus over the past couple of decades. There probably are two that are most important. The first is the development of computerized corneal topography. This was something that was just being looked into when I was finishing my residency back in the mid-'80s. Heretofore, but before that, all we had was the B&L manual keratometer and some placido disc imagery. And it was really the advent of topographic analysis that allowed us to understand corneal shape and structure, and in particular, allow us to diagnose keratoconus at its early stages. The second most important thing, I think, clinically for the keratoconic patient was the development of corneal collagen crosslinking. My disclosures are as you see here. Keratoconus is inherently a biomechanical problem. The cornea is structurally weak and thin. The primary event probably caused by slippage of the collagen fibers. There are typically interlamellar adhesions, particularly in the anterior stromal structure, that give support to the corneal dome, and also lamellar insertions from the stroma into Bowman's. These anchoring fibrils and circumferential annular fibrils around the limbus are what give the cornea its structural support, allowing it to be an optically efficient, clear corneal dome. Because of the structural weakening in keratoconus, there is a progressive deformation that leads to irregular astigmatism, as we know, increase in higher aberrations, and eventually corneal scarring and the need of transplantation in a number of patients. It's now back over 2 decades that Theo Seiler and his group, led by Eberhard Sperl, thought of the concept of corneal collagen crosslinking. They said that the aim of this study was to investigate the possibility of induction of crosslinks in corneal tissue in order to increase the stiffness as a basis for future conservative treatment of keratoconus. One of these things that brought this up to the fore was the development of refractive surgery and early detection of corneal ectasia in some early laser refractive surgery patients. So the thought was, if corneal weakness is really what causes keratoconic progression, maybe strengthening the cornea would stabilize the disease process. Well, in fact, it does. The crosslinking we do today, as you all know, involves the interaction of ultraviolet light at 365 nanometers with riboflavin, which induces the production of both activated riboflavin and reactive oxygen species. There is an oxygen-dependent pathway and an oxygen-independent pathway. Suffice it to say, however, what these do is they lead to a cross-linking in molecules in the cornea. Now, it was thought that initially these linked collagen fibrils together, but certainly if you look at EM, as you see here, the distances between the fibrils simply is too lengthy for an actual cross-link to cement them together. More than likely, the cross-links that we see from the collagen cross-linking procedure are from collagen to the proteoglycan matrix. In any case, this has the effect of stiffening the cornea. Much like aging changes naturally cross-link the cornea. If you're a corneal transplant surgeon, you know that when you cut a older cornea, it's much crisper and stiffer than a young cornea. Well, collagen cross-linking was shown to increase the corneal stiffness by about 300 to 400%, increasing Young's modulus by 4.5%. You see in the upper right-hand photo, this is the oculus corbis, which measures in real time the tempo and degree of deformation of the cornea. You can see how in a keratoconic cornea, there is much more oscillation and deformation, and in the normal cornea, there's less of an oscillation and deformation. So we can use biomechanical instruments such as this to assess the results of cross-linking as well. The first case in the US was performed in February of 2008, and cross-linking in the US was approved in 2016. The primary indications being treatment of progressive keratoconus in patients 14 years old, and the treatment of corneal ectasia after refractive surgery. People always ask how to define progressive keratoconus. Well, that can be changes in refraction over time. Most people would use changes in corneal topography, be it maximum keratometry or other quantitative indices of keratoconic irregularity in order to see and ascertain if a patient is progressing and their degree of progression. Let's look at the cross-linking procedure. I'm only going to discuss here the standard Dresden protocol epithelium off procedure. There's a lot going on now, obviously, with transepithelial procedures, higher fluences, accelerated cross-link, and the like. But let's just go over the standard procedure. We like to use a 9mm corneal protector that is soaked in an alcohol. We leave it in place for about 30 seconds, and then the tissue will easily remove in a sheet from the surface. Riboflavin drops are then administered every 2 minutes for 30 minutes, and we check riboflavin uptake as you see in the bottom photo. You want to make sure there's complete penetration throughout the cornea, and we also look to see that there is flare in the anterior chamber, indicating that the riboflavin has completely saturated through the cornea. Now, one shouldn't begin the procedure unless the cornea is 400 microns thick. This is in order to protect the corneal endothelium. If less than 400 microns, we administer hypotonic riboflavin, that is riboflavin that is simply in a distilled water base, every 10 minutes for 2-minute sessions until the cornea swells above 400 microns. The instrument is then centered, and ultraviolet exposure for 30 minutes at 3 milliwatts per centimeter squared is typically introduced. Followed by a bandaged contact lens. We like using antibiotic and corticosteroid 4 times a day for 1 to 2 weeks. We remove the contact lens generally at day 4 or 5, and typically the epithelium is healed by this point. Let's look at the results, both of the multi-center clinical trial for keratoconus as well as for corneal ectasia. There are actually 2 clinical trials that were performed, one for a keratoconus arm and one for a corneal ectasia arm. Looking at optimal outcomes, the primary efficacy criteria for the US FDA clinical trial was a mean change in maximum keratometry on the Pentacam of greater than 1 diopter between treatment and control, those who received cross-linking and those who didn't. Kmax was chosen because it is within one center and one piece of diagnostic equipment, very reproducible, and also reproducible across centers. So it's a reliable proxy for the patient's degree of keratoconus. The results are shown on the graph on the right. In the keratoconic group, there was an actual improvement of 1.6 diopters in Kmax. So there was a flattening of the cone and improvement in topography compared to progression of 1 diopter in the control group. The Ectasia group had a somewhat less robust result, flattening 0.7 diopters, whereas the control group steepened by 0.6 diopters. We did a sub-study looking at the KC indices supplied by the Pentacam. And we found that 3 of these, the index of surface variance, that is how irregular is the surface, the index of vertical asymmetry, which looks at the power of the lower part of the cornea compared to the power of the upper part of the cornea, which is probably the most diagnostic of keratoconus, and the keratoconus index, which also includes Kmax and the degree of the cone. And we found that these 3 were significantly improved after cross-linking. So both Kmax improved and these quantitative descriptors of corneal topography in keratoconus improved as well. Now, this was corroborated by our findings on wavefront analysis, where both ocular and corneal higher order aberrations improved 1 year after cross-linking. Spherical aberration, total aberrations, but in particular coma, a vertical coma, which again is the differential between the top and bottom of the cornea, decreased. And this is something that you would expect to see if there is an improved keratoconic topography. Looking at vision, over the course of a year, there was about a 1-line improvement in both corrected distance and uncorrected distance vision. And we also did subjective visual function surveys for patients pre and post-operatively, and found that a number of indicators of subjective vision improved. Night driving, glare, halo, starburst, difficulty reading, those all improved after the procedure, so patients subjectively noticed an improvement. Remember, cross-linking itself is not used with the goal of improving vision or improving topography. Those are welcome side effects. However, cross-linking's goal is really strictly to prevent progression of KC. We're going to see a few other ways when Dr. Greenstein talks to us again, how we can even further improve a corneal topography. Looking at the natural history and wound healing, as well as safety indications, we published several years ago an analysis of corneal collagen cross-linking associated haze. From the early days of cross-linking, it's been noted that early on, there is a fine dust-like haze after cross-linking, which evolves into a demarcation line about 250 to 300 microns deeper in the cornea. This is ostensibly the depth to which the cross-linking is taking effect. On these Pentacam shine plug pictures that you see here, preoperatively, the cornea is pretty clear. At 1 month and 3 months, there is an increase in densitometry haze. This then decreases at 6 months and goes back to normal at 1 year. So one can expect a corneal haze that, again, worsens at a month, plateaus at 3 months, and improves to baseline over the course of the year. The corneal densitometry now is an integral feature that we use frequently of the Pentacam. These were all done by us in the early phases where we did it all by hand. What causes the haze? Likely keratocite apoptosis and repopulation and changes in collagen structure cause the clinical haze, and then healing diminishes it over time. In the U.S. clinical trials, we assess safety in 512 eyes, and the most reported adverse effect was indeed the corneal collagen crosslinking associated stromal haze, which again dissipated in most patients and usually does not have any adverse visual consequences. Most other adverse events were related to epithelial removal, punctate keratitis, eye pain, everything that you would expect with a healing epithelium. There was one ocular severe adverse event, and that was one corneal ulcer. We're now looking at our results 10 years after our original study. We've recently looked at 29 eyes from the original FDA study cohort and found generally stable Kmax, uncorrected and best corrected vision, whereas we saw progression in those eyes that were left untreated. Finally, the question comes up, who should we treat? Dr. Greenstein and I underwent a study several years back looking at characteristics that influence the outcomes of collagen crosslinking. We looked at 104 eyes, looking at a number of preoperative characteristics to see how they related or affected or were associated with outcomes of maximum keratometry in the Pentacam and best corrected vision. What we found with relation to corneal topography and maximum K was that a higher preoperative Kmax was independently associated with greater improvement in maximum keratometry. So, in patients who had a Kmax of 55 or more, they were 5 times more likely to flatten 2 diopters or more at 1 year. So 45% of patients over 55 flattened substantially compared to 13% under 55. So worse patients, topography-wise, did better. Similarly, when we looked at spectacle-corrected vision, though there was an average of 1 line improvement, about 22% of patients improved by more than 2 lines, and 3.5% of patients lost 2 lines or more. And we found that worse preoperative best corrected vision was independently associated with more improvement in vision, such that if patients were 20/40 or worse, they had an almost 6-fold likelihood of improving 2 lines or more compared to patients with better vision. So 20/40 or worse, almost half the patients improved 2 lines or more, 20/40 or better, only 11%. And when we stratified this to only 1 line of visual loss, recollect, only 3 eyes in the whole study lost 2 lines of best corrected distance vision, and they had no defining characteristics. But when we looked at those few patients who lost only 1 line, though this was not statistically significant, patients with excellent vision lost 1 line at a rate of 15%. Patients with worse spectacle-corrected vision lost 1 line at only 8%. So this may suggest that there is a somewhat increased risk of losing a little bit of vision if you have excellent vision to start with. So if you have a 20/20 patient, that's the patient you need to counsel about postoperative vision and visual loss. So understanding this, the goal of selecting patients is to define what we're looking for. Again, the most important aspect of cross-linking is to stabilize disease progression. So I think that if patients are progressing, they should have collagen cross-linking. In some circumstances, especially in patients with excellent vision, we may want to follow the patient and make sure there's no progression because we want to avoid any loss of the best vision. And in some circumstances, we will do the treatment to simply improve corneal topography. Now, there are a number of ways, as I said, that we can improve corneal topography using adjunctive procedures, Intacs, topography-guided PRK, ICL, CK, and importantly, probably the biggest adjunct that we use are specialty contact lenses. So I want to turn over the podium now to Dr. Gelles, who can discuss the contact lenses and the appropriate use in the management of our keratoconus patients.
Excellent. Thank you so much, Peter. So guys, let's go ahead. We'll jump right into this. So when we talk about the modern management of keratoconus and visual improvement, if we look at the way things were done in the past, the traditional management was to use glasses for individuals who were correctable with those. If they were not correctable with the glasses, we then would move to corneal gas permeable lenses. And if they were still not correctable, had complications or severe central scarring of the cornea, reducing their visual acuity with the corneal gas permeable lenses, then they would undergo corneal transplants. And based on the CLEI study and other studies out of the UK and from around the globe, rates of corneal transplantation range from about 10% up to 22%, depending on where the data is coming from, the CLEI being around 12% or so. When we look at the modern treatment, essentially what we have are two divisions with this, which is when we have a patient who's progressing, we're going to treat them with corneal collagen cross-linking. And then we want to look at ways to visually rehabilitate these individuals, like what we had seen Dr. Hersh mentioned before, which is either specialty contact lenses, which I'll discuss, or corneal surgery, which Dr. Greenstein will discuss right after me. So with contact lenses for keratoconus, there's a variety of different modalities these days. There's seemingly an endless expanse of various designs and various modalities. We have everything from standard soft lenses to custom soft lenses, obviously our classic choice with corneal gas permeable lenses, and then also hybrids, piggybacks, and scleral lenses. So we have a giant variety of lenses for individuals with keratoconus. With so many choices, how do you choose? When do we choose from going from the classical choice of like a corneal gas permeable lens to something like a scleral contact lens? Well, Zhang's group, or Zhang's poster from GSLS in, I believe, 2014, this was from Pacific University. Essentially what they did was they looked at corneal elevation differences in individuals with keratoconus and put lenses onto the eye and looked at who would be successful with a corneal lens versus those who would be successful with a scleral lens. And what they found was a difference of 350 microns of elevation from the top of the cornea to the bottom of the cornea. So from here to here, the elevated portion to the depressed portion of the cornea was statistically significant. Less than 350 microns of elevation led to about an 88% chance of success with a corneal gas permeable lens. Now, when we look at this, what are we looking at essentially? Well, we're putting a best fit sphere through the corneal surface to be able to evaluate the deviation from a perfect dome shape. Right? So what you can see here is when we do that through a keratoconic cornea, you can see the depression down below here where the cornea dives away from that best fit sphere, whereas up top, the cornea is forward from that best fit sphere. So you can see a flatter or rather more elevated portion of the cornea up top and a depressed or steeper or more a diving away shape of the cornea down in that inferior portion. Now, this elevation map is not only extremely important for contact lenses and planning with that. Essentially, the way that they are using this is measuring the asymmetry of the cornea. But also, this elevation map has an extreme value for surgical planning, where you can use various different methods to fill in the depression or reduce the superior elevation between the areas of the cornea to create a more symmetrical corneal shape. And Dr. Greenstein will talk more about this application when he reviews those surgical options. Now, when we look at lens selection, you can take a look at this individual with a moderate amount of keratoconus here. And you can see that this keratoconus is very central. These are 12mm maps derived from the Pentacam. And what you can see is if we look at the IS ratio, which is essentially looking at the difference from the top to the bottom of the cornea based on where the location of Kmax is, at a 6mm optic zone. And what we're looking at is the difference that's created there. And you can see that that's 2 diopters on this individual with a very central cone. So not much difference between the top and the bottom there. Now, when you look at their elevation map, which is classically presented in the Pentacam, this is a elevation map with the best fit sphere on what we call float. Float is essentially where you're balancing it through the depressed and elevated portions of the cornea to find a best fit through the corneal tissue to describe that. So you can see that we have a very small elevation here with depressions on either side. Now, when you turn the float off, what you can see is we get a true elevation through this where we can see the elevated portion of the cornea and the depressed area of the cornea very, very clearly. And you can see that this individual has about 126 microns of difference from the top to the bottom of the cornea. Now, what we can do with this Pentacam data is put that into the Wave design software and be able to look at lenses that we could fit onto these eyes. And we can get simulations of how these lenses would fit on the eyes and their fluorescein patterns that would be created. So you can see on the left here, this is what a spherical lens would look like on this individual. You can see that we would have a moderate amount of edge lift that's present there. And you can see that we would have a little bit of apical bearing on the cornea right here. Now, if we just made a simple change to make this this lens a geometrically symmetric or a toric corneal gas permeable lens, you can see that we have much better alignment on this individual's cornea, and we could easily fit this individually successfully with a corneal gas permeable lens. Now, if we take an individual that's much more severe, you can see this individual has a 13.5 diopter IS ratio and nearly 556 microns of elevation difference between the top and the bottom of the cornea. If we then go ahead and put this into simulations, you can see that the spherical lens ends up with a tremendous amount of edge lift here at the inferior portion, well over 100 microns of elevation in that inferior portion, and you would see that lens just significantly drop on the cornea. Now, when we go to a toric lens, you can see that this improves, but you can see that we still have a significant amount of edge lift present. Now, with the software, you're able to derive entirely free-form lenses. And if we use one of those, we can go ahead and take care of this. However, most individuals, if you're using diagnostic lens sets to fit lenses, you're simply not going to be able to fit a lens to this eye. So we went through a retrospective review at our clinic here, looking at individuals who were successfully fit with keratoconus. And we looked at about 450 individuals. Now, the purpose of this study was to describe what lens might be successful on what eye. So we looked at over 737 eyes in various different forms of lenses for keratoconus. And what we found was this: when we looked at Kmax and K-mean, there was no statistically significant difference between the K-means of piggybacked and scleral lens wearers. There was also no statistically significant difference between Kmax or K-mean in individuals with custom soft lenses or RGPs, indicating that those individuals could have been wearing either lens based on their geometry. What we found next was if we created a cutoff of 55 diopters, we formed 2 groups: soft lenses and corneal GPs in one category, hybrids, piggybacks, and sclerals in the other category. And if we created a cutoff on K-mean, we have 50 diopters, we again found two groups were presented here. So when we then broke this down into IS, what we found was that there was no statistically significant difference between custom soft, corneal gas permeable lenses or hybrid lenses. And when we used a 10 diopter cutoff, what we found was, again, there were two groups formed, indicating that there was a severe category that needed the piggybacks and scleral lenses, and another category that ended up being in those standard soft, custom soft, RGP, or hybrid categories. Now, the other thing that we found was when we grouped these individuals by their manifest refractive data, what we found was that there were three groups formed. The individuals in standard soft or custom soft were generally correctable with their manifest refractions to greater than, or rather better than, 20/30, whereas individuals wearing hybrids and corneal gas permeable lenses corrected to about 20/40 or a little bit worse, and individuals in piggybacks and sclerals ended up correcting to about 20/50 or worse. Now, what we found was that everybody in a contact lens seemed to do very well at around an average of 20/25 visual acuity, despite what type of lenses that they wore. So this is indicating that the type of lens that they are wearing is mostly determined based on the geometry, with visual acuity being the secondary outcome on that. Now, we also looked at lens failures, and what we found was that RGPs were the most replaced design. And this is typically because practitioners use RGP lenses most commonly for individuals with keratoconus. But what we did find that was very interesting was that all lenses were replaced. There was no such thing as one lens for all individuals with keratoconus. And what we found was, as we looked at those metrics of topography, such as maximum keratometry, what we found was we looked at the differences between those individuals who were successful and those individuals who failed. And what we found was that there was a statistically significant difference in maximum keratometry in the soft lens and RGP group between the successes and failures, meaning that those individuals wearing soft lenses or RGPs were too steep for their RGPs or soft lenses in the fail group compared to the successful group. Again, we looked at that in mean keratometry, and again, we found the exact same finding. But when we looked at IS ratio was statistically significant for differences between success and failure for the soft lens, the RGP, the hybrid, and the piggyback category, indicating that this is the most important metric for figuring out what lens may be successful on an individual. And then we can also note that scleral lenses had no statistically significant corneal metrics that indicated failure for these. So what we came up with was an algorithm for this, which was essentially that you would take the corneal topography, look at the IS ratio between the eyes, looking at a 10 being the cutoff, a K max of 55 being the cutoff, and a K mean of 50 being the cutoff. And when you had an IS ratio of greater than 10, or a K mean or a K max greater than 55 or 50, you would go into a scleral lens or a piggyback lens. If you were less than those metrics, then you would look at visual acuity. And if the individual had a manifest refraction visual acuity worse than 20/30, then those individuals would be best served in an RGP or a hybrid. And if they were better than 20/30, they would be best served in a custom soft lens or a soft lens for keratoconus. Now, what we find here is that the elevation data that Zhang's group and the IS data that we've presented here is actually very similar. When I went back to the data and looked at the elevation differences of an individual with a 10 diopter IS ratio, what we found was that those elevation differences were about 350 to 400 microns, indicating very close correlation with what Zhang's group had seen. Now, this must be confirmed, but the preliminary data that we have collected seems to correlate. Now, we're also going back and correlating this data to the Pentacam metrics, such as the ISV and the IVA. Now, scleral lenses failed for another reason other than corneal tomography or topography. Now, what could this be? Well, there's a variety of different factors, but anatomic factors such as complex scleral geometry is one of those. Now, if you look at Denaire's study, what he found was that very few eyes actually had a spherical or toric scleral shape. What they mostly had was asymmetric or highly asymmetric scleral shapes and that made up nearly 66% of eyes had these highly asymmetric shapes. Now, how do we find these asymmetric shapes? Well, we can get data derived from the Pentacam to be able to look at this scleral shape through the CSP report. What this does is it takes 5 images of the sclera and stitches those all together to be able to create the scleral shape. Now, this is done with the Scheimpflug imaging, so there's no sodium fluorescein required. And this data can then be exported into various different design programs to create freeform lenses. Now, the data that's presented by it is things such as the angle of the sclera and the various different quadrants of the eye, as well as the quadrantial sagittal depths of the eye, and then also the very important white to white, as well as estimates of the different sagittal depth data that you may need to select a first lens out of a set if you were going to go that way. However, the most important portion of this is that you can export this data or surface data into the design software from Wave to be able to create a surface-based lens. Now, this can also go into various other design software that's out there, such as ScanFit or iSpace, to be able to create these freeform lenses. Now, we did another study at our center looking at comparing the number of lenses necessary to achieve a final fit by utilizing impression, profilometry, and diagnostically fit scleral lenses. This was a retrospective review, and we looked at nearly 562 eyes. And what we found was in the diagnostic category, there was an average 2.4 plus or minus 1 lenses to get to a finalized lens. Profilometry, or rather data-derived lenses, took about 1.9 lenses plus or minus 0.7, and impression took about 1.5 plus or minus 0.6. So our conclusions from this is that profilometry-derived lenses allow for more sophisticated designs than the diagnostic lenses that we're capable of creating. The endpoints are also closer with profilometry than they are with diagnostically derived lenses. And this level is approaching the levels based on the physical mold of the eye, which is derived from a impression, meaning that scan-based lenses are getting very, very good and are clearly superior to our diagnostically fit lenses. So having one of these devices can really, really improve the ability to create these customized lenses for these individuals. With that, I'm going to go ahead and turn this back over to Dr. Greenstein so he can go ahead and discuss surgical interventions for individuals with keratoconus.
Okay. Thank you, Dr. Gillies. So we'd like to conclude tonight with surgical visual rehabilitation for patients with keratoconus. And I think that this portion of our talk does kind of synthesize a lot of what we've talked about before using advanced diagnostic imaging and technology, which has now helped us guide some of our surgical approaches to getting better results for patients with keratoconus. So Intacs, which have been used for years now in patients with keratoconus and are a corneal ring segment, which is a 150-degree segment in various thicknesses that is made out of PMMA, can be placed in the cornea to flatten the cornea and improve symmetry. And so if we look at corneal topography here, here's a patient before surgery. Their segment was placed in the area of the cone, the steepest areas here, and the cone flatten. And when we look at the difference map, we can see the flattening down below, some mild steepening up top, and the improved corneal symmetry from the Intact segment. How do Intacs work? Now, the Pentacam and some of the elevation maps that Dr. Gelly showed have been very instrumental for us to understand how Intacs work and develop some surgical planning for Intacs placement. So this is kind of a crude image for how we're reshaping the cornea. But when we look at the keratoconic cornea and we place an Intacs channel, which can be seen in white in the cornea, and then we place the Intact segment, what we're essentially doing is elevating the cornea so that we reshape it and there's corresponding flattening inside of that segment. And that can be seen with the Scheimpflug image on this slide here. So the intact segment can be seen, the cornea can clearly be seen that is elevated right over the top of the segment, and then there's flattening of the cornea in the central portions of the central to the segment. Now, these are those elevation maps which are relative to the apex of the cornea, which Dr. Gelles went through for contact lens fitting. And what we can see in these maps is that when the intact segment is placed in the area of depression and the cornea is elevated, the center of the cornea becomes more symmetric. And if we highlight the center here, what we can see is that before surgery, there is a more depressed cornea inferiorly and more elevated superiorly. And clearly after surgery, there is more symmetry between the superior and inferior portions of the cornea. These maps have helped guide us in placing intact segments and getting better results. And in our report from our prospective trial on placing intact segments, in general, we were seeing about 2 lines of uncorrected visual acuity, improvement in uncorrected visual acuity, about 1 line in corrected visual acuity, and about a 2.5 diopter flattening of Kmax. So these numbers are more robust than cross-linking alone, but still, there are patients who need either more correction or may benefit from alternative procedures. And one of the newer procedures available to us is topography-guided PRK. This is an off-label use of the procedure for patients with keratoconus. But we essentially use the excimer laser to alter corneal curvature. And the way that works is instead of LASIK, where we use the prescription to guide our treatment, we use the topography maps to guide the excimer laser treatment. So we can see in the picture on the left, a classic example of a patient with keratoconus, inferior steepening and superior flattening. We see the map generated by the topographer before treatment, which shows a area that the laser would like to flatten over the steep portions and steepen up top over the flat portions. And what you can see in the picture on the right is the post-operative map, much flatter down below, much steeper up top, and a much more symmetric cornea. In a retrospective review of keratoconus patients that we treated at our center with topography-guided PRK alone, we saw that uncorrected visual acuity was improving by an average of 4 lines, and best spectacle-corrected visual acuity improved by an average of 1 line. Maximum keratometry flattened by about 3 diopters with a maximum flattening of about 5.7 diopters. So now, compared to cross-linking alone and even intacts, we clearly see a more robust flattening with topography-guided PRK, and we can also see a more improvement in uncorrected visual acuity. Topography-guided PRK can also be used after intacts treatment to further improve patients' vision, and we'll be publishing on those results shortly. One of the most exciting advances in keratoconus treatment is our new customized tissue addition for keratoconus, or CTAC. In this procedure, we use a E-beam sterilized tissue that we customize with the femtosecond laser and place it through a channel similar to the intact channel to flatten the cornea and improve corneal symmetry. The tissue shaping is done with the femtosecond laser, where we first cut the tissue with the laser and then create a crescent shape to be placed through an intact channel. And we are now using all of the diagnostic equipment that we went over to customize how we place the segment, in what thickness we place the segment, and at what length we place the segment, so that it encompasses the entire cone, as can be seen in the left in the axial map, and the entire area of depression, as can be seen in the central elevation map. And when we place the tissue in that area, This is what it looks like on the right on the first day after surgery. We can also customize the corneal inlays by thickness. So the thicker the segment we place and the more we elevate the cornea, the more we can flatten the cornea. If we place a full thickness tissue, as can be seen in the pictures up top, we can see that the cornea flattened by around 19 to 20 diopters just interior to the segment placement. If we place just under half thickness, we can see that the cornea flattens by just less than half of that, or about 9 diopters. The inlays can then be customized in any further thickness to modulate this flattening. Now, we have begun to look at this procedure as part of a prospective clinical trial, and these are some of our early results on the first 7 patients who were treated. These are very early results. These are 1-month results for all 7 patients, and for 4 out of the 7 patients, 6 months results were available. And that what I want to point out is that these procedures so far has been done on very advanced cases. So the average maximum keratometry was almost 82.5 diopters in the patients that we placed these inlays. The thinnest pachymetry was about 356 microns. So these are clearly patients who are too severe to have an intact segment placed or to have topography guided PRK alone. But these are our early results. And most of these patients did have a full thickness tissue placed. And so what we can see is that the average maximum flattening that we saw was just under 20 diopters, both at 1 month and 6 months. The average flattening of mean keratometry was 9.6 diopters at a month, and among the 4 patients who were treated out to 6 months, that was 5.6 diopters. How does this compare to intacts alone? So when we place intacts in the cornea, and again, this is from our prospective trial, when we looked at single segments of varying thickness, we saw as the intacts thickness increased, the flattening that we saw increased as well. But now we're seeing those numbers an even more robust flattening. With half thickness tissue in the CTAC procedure, we're seeing about 9.5 diopters of flattening. And with full thickness tissue, we're seeing just under 20 diopters. But really exciting is the improvement in visual acuity. And again, these are very severe patients. And we're seeing on average both uncorrected visual acuity and best spectacle corrected visual acuity improve by about 4 logMAR lines. So we saw patients at 1 month improve by, on average, a Snellen equivalent of worse than 2400 to about 2160, and a best corrected visual acuity, a Snellen equivalent just better than 2200, now improving to 2070. So this CTAC procedure appears to be very promising for patients with severe keratoconus, and we're further analyzing it for patients with more moderate and mild disease. So again, we covered a lot of ground tonight, and we hope that we conveyed that modern management of keratoconus has really changed with modern diagnostics, with modern treatments such as crosslinking, and modern contact lens fitting and visual and surgical treatment. We can offer so many more options to our keratoconic patients. You know, each of these topics can probably be almost an hour talk in and of themselves, but we hope that we were able to convey kind of the breadth of modern keratoconic management in this talk. So thank you for your attention, and I guess we'll go to questions.
Thank you all so much for that absolutely fascinating presentation. I know we are running a little bit over, but I do want to give some of the doctors that have entered their questions into chat an opportunity to have their questions answered. I'm going to go ahead and start with a question for you, Dr. Greenstein, which is a question about the topography-guided PRK procedure. After you perform the topography-guided PRK? Do you crosslink before, after? How do you prevent the cornea from progressing after, the ablation?
So that's an excellent question, and we do recommend to all of our patients that they should undergo cross-linking as a part of the topography guided treatment. So the vast majority of the patients who we treated had cross-linking first, and their corneas had been stable, where we then performed topography guided PRK for them and followed their corneas closely after. We're now looking at a new algorithm that we created to do a topography guided PRK with simultaneous cross-linking, and we're hoping to be publishing on those results shortly as well.
Perfect. Thank you so much for that answer. Next, I have a question for Dr. Gellis. It's regarding how to choose between a hybrid lens versus a scleral lens, and do you take into account the cell density with specular microscopy when deciding whether to do a scleral versus a hybrid lens? And what in specific would you think about an eye with less than 800 cells per millimeter?
Well, a very loaded question there. So we'll go ahead and we'll start off with, how do I choose between a hybrid and a scleral? Well, if you follow the algorithm that we proposed, generally I would be using a hybrid lens on a cornea that has less than 55 diopters of K max, less than 50 diopters of K mean, or an IS ratio, and most importantly, the IS ratio of less than 10 diopters in that 6 millimeter optic zone. If they were greater than that, I wouldn't even bother with going to a hybrid lens. I would just go straight to a scleral lens. Now, when we talk about corneal cell density, the 800 cells is really just a guideline that was proposed by Chris Sint. Now, this has been repeated multiple times, but doesn't really actually have any scientific evidence behind it. What I find in our, it's just really a good guideline, though, to kind of indicate, well, we may have issues around here. What I think is more important than that is to look at the quality of those cells when you're looking at the specular microscopy. What does the imaging look like? Are there frank bullae? Are there cysts? What is going on with that endothelium? I've seen eyes with much less, around 500 or even 400 cells, do very well in a scleral lens. I've seen eyes that have much more, that around 1,200 or 1,500 cells, do very poorly under a scleral lens. So I would say that that's a decent guideline, but I wouldn't say that it's a hard and fast rule. The best thing that I've found with all of my research and work here has been to actually put a lens on an eye, let the patient wear the lens and for about an hour or 2 hours, and then look at the cornea and see if the cornea is edematous. Is it showing signs of microcystic edema or anything like that? But what you can really look at that's very important is on the Pentacam, you can look at the changes in the corneal thickness. Obviously, if the cornea is swelling because of hypoxic stress, you're going to have an increase in corneal thickness, and you can see that on the difference maps that are created on the Pentacam. Really, everything just comes back to imaging, and as you can see, imaging is the most powerful thing of what we did tonight. It shows you progression, it shows you what contact lens is, it shows you complications, it shows you surgical planning. Just go back to the imaging, you'll see whether or not you have an issue or not.
Great. Thank you so much for that answer. Dr. Hersh, this next question is for you, and it's about cross-linking. A lot of doctors are really curious about the epi-on procedure. I know we talked mostly about epi-off. What are your thoughts on the epi-on procedure, and your thoughts on the new data coming in on that?
I think epi-on's getting better and better. The first difficulty in epi-on was the ability to get riboflavin into the stroma through the intact epithelium. I think to a large extent that difficulty has been surmounted. Additives such as benzalkonium chloride and others to the solutions, different ways that we apply the solutions, allow us now to soak the cornea properly. We've done studies where we essentially use a hypotonic solution with benzalkonium chloride and can get a ready and complete saturation of the cornea. But the other things of concern are, number one, blockage of the incoming ultraviolet light by the epithelium, especially if the epithelium is saturated with riboflavin. So that's 50 microns right there where the effect can be blocked. And also the effect of oxygen. Because oxygen tends to be rapidly depleted, and even more so if the epithelium is intact, the oxygen-dependent pathway of the cross-linking may be mitigated in an epi-on cross-linking, which may make it less effective. Now, some ways around that include pulsing the light. So the light goes on, the light goes off, typically 1 second on and 1 second off, and that may help to replenish the oxygen. Also, studies are going on of using actual oxygen in the atmosphere around the crossing that may aid it as well. So in our studies, we found effect, but not as great an effect as we have found with epi-off. For instance, we have flattening, I think, and this is off the top of my head, of 0.5 to 0.6 diopters in epi-on compared to 1.6 with epi-off. Using the shine plug densitometry, we have found less corneal haze in epi-on, which is an advantage because obviously you'd rather have a much clearer cornea than have any corneal haze. But as corneal haze may actually be an indicator of efficacy of the cross-linking, it's unclear whether that is an untoward effect or not. So I think there's a lot of work going on in epi-on. I think the way we're doing it today works, but doesn't work quite as well as epi-off. And I think there are going to be innovations as time goes on that will make it a more effective procedure as we learn more.
Perfect. Thank you for that very thorough question. I have one more question for you, Dr. Hersh. During your presentation, you mentioned a cutoff of 400 microns of corneal thickness, and how actually patients with better visual outcomes already are kind of indications of maybe losing lines of vision. Are there any other risk factors for poor outcomes with cross-linking treatments?
Well, the 400 micron stipulation was taken and extrapolated from laboratory work out of Theo Seiler's lab, which indicated that actually there is enough of a dissipation of the ultraviolet energy at 300 to 350 microns that the endothelium is not affected. Now, we have done studies showing that the endothelium is safe during the normal cross-linking procedure. When we looked at it in the US clinical studies, there was no effect on endothelial cell density. We also looked at using hypotonic riboflavin rather than dextran riboflavin to increase the thickness of the cornea throughout the procedure, and that led to no increase in endothelial toxicity. So I do think that rule is important, but I think there are ways to thicken the cornea, either hypotonic riboflavin or other modalities that allow thinner corneas to be treated. The stipulation regarding the best corrected vision is simply that if a patient has 20/20 going into it, there's little upside potential that they're going to get from the cross-linking besides stabilization. And because of the healing and because of potential haze, they may be of slightly greater risk of losing a line, which if you're a CRISP 2015 or 2020, can be meaningful. So I still think that somebody, young kid progressing with 20/20 should have cross-linking, but they need to be counseled appropriately. Another contraindication, maybe in some circumstances of corneal scarring, we have seen more haze in patients who have more corneal scarring discharge. So the repository of fibroblasts and keratocytes that reside in a scarred cornea may lead to greater scarring and haze formation afterwards.
Perfect. Thank you so much. That is all the time we have for tonight. You've been wonderful presenters. I feel like this has been absolutely fascinating, and I'm sure all of our audience agrees, especially given the number of questions we unfortunately just don't have that much time for. But hopefully we can answer those either via email or via even future webinars. Everyone, this has been National Keratoconus Day, and I hope you all have a great night. If you doctors want to say final goodbye or any final thoughts.
Yes, well, thank you again to Oculus for sponsoring this, and certainly any of us be willing and happy to hear from you should there be any further questions that you have regarding the materials tonight, and look forward to seeing everybody on a webinar in the near future.
Yes,
Have a
thank
great
you.
night. Have a great night, everyone.
Good night, everybody.
Night.